Okay, great.
Yeah.
Okay. So good afternoon, good evening, good morning, depending on wherever you are located. Today is the last part of our webinar series hosted by the Aortic and moderated by our President-elect, Professor Miriam Motibi. During the latest webinars we did together, we discussed a lot of issues in our current model of publishing system in oncology, including predatory journals, including plagiarism, retracted articles, ethical issues. And today we are also interested to discuss the clinical relevance of the results of clinical trials beyond statistical significance. This is also a very important and relevant topic for our daily practice and also for research. So today I am very, very happy to introduce my friend, my colleague, a very known and great global oncologist focusing on helping and supporting global oncology initiatives. He is a medical oncologist from Italy. This is Dr. Dario Trapani, who is currently an assistant professor at the University of Milan, and who is also a practicing medical oncologist in Italy. So he was interested during his career to be expert in breast oncology. He did a fellowship at the Dana-Farber Cancer Institute, and also he is highly interested in common sense in oncology with a more focus on global oncology initiatives. So today, Dario will talk about how to appraise the content of clinical trials with a focus on phase 3 randomized and controlled trials. Dario, the virtual podium is all yours.
Thanks, Khalid, and good afternoon, good evening to everybody. It's really my greatest pleasure and honor to join you today. Sorry for my voice, it's a little bit low than normally it is, but it is what it is, just a little bit cold. I'm really honored really to join this initiative because Khalid has really developed a lot with the Arctic, and it's really my pleasure to give some contribution to this amazing education initiative that all the Arctic, Dr. Mutaibi, and of course also Khalid, you are all leading for this important educational output. And today I really want to discuss with you, this is sharing ideas, so share your idea, share your comments, make questions. It's really like how we intend and how we should discuss significance with patients. What is a patient-centric value and why all it is statistically significant may not be really clinically relevant at all. And I want to start with you with just like, this is my declaration of interest and I have my interest. We really like a first slides asking really you what's according to your perception of clinical trials and medical oncology or the broadly oncology delivery. What is a relevant endpoint and what we should measure to make sure patients live better and live longer when they are diagnosed with a cancer diagnosis. And in fact, I have here some declination or common definitions that we use in clinic to measure what's the improvement, what's the progress in cancer treatment. And you see that for some, improvement of the outcome means that there is a longer disease control, there is treatment shrinkage, tumor shrinkage, there is a longer time to the disease recurrence. For some people, it's really survival and how people feel and live every day. That's quality of life. For other people, it's really everything related to plasma biomarkers. That is really like measurement of tumor-related metrics. And so at this point, when we discuss clinical endpoints, we have to understand what are the endpoints we are evaluating and if they are patient-centric, if they are relevant for the patients that we are treating at this point. We commonly, refer to these as quality of life and overall survival that are patient-centric, robust, and gold standard clinical endpoints. And then we have other declinations that are more cancer-related. They are, cancer-centric. They are not patient-centric. And these are progression-free survival, how the disease shrinks, and how the disease is controlled and responds to the treatments, disease-free survival, or even the measurement of biomarkers that's completely independent from the patients. It's something only related and sticking to the cancer itself. So as you see, of course, often it's a question of perspective. In fact, for some people, it's more important to measure something that is important, it's patient-centric and it's relevant, like quality of life and overall survival. And this is definitely something important first for patients. when a patient is diagnosed, and this is really my clinical practice with a cancer, they really want to know how long we are able to make them live and what will be their quality of life. Because cancer is a high impact diagnosis on patients' lives, and it's also high impact on the life expectancy. And of course, it can create a lot of issues like symptoms, pain, and things like that. So the patient will never really ask, I want a longer progression-free survival. They will say, I don't want to have pain, I want to live longer. I want my quality of life to be preserved as much as possible. They will ask if treatment gives toxicity and what kind of. And of course, on the other hand, we have other type of people that measure some kind of quicker, like faster endpoints, like progression-free survival, disease-free survival, or biomarkers, because they really want to get faster results. And this is really commonly from the trialist, or even who is investing on some molecules like industry. And the endpoints, like progression-free survival and disease-free survival, they're not necessarily patient-centric. And sometimes they don't really correlate with patient-centric outcomes. So where do patients stand, in this kind of discussion between gold standard endpoint, like quality of life and overall survival, and the other type of measurements like PFS, DFS, and biomarkers? And as you see in this work, that has been produced by the Canadian working group from the Ontario University in Queens, you see that when the patients were asked, what is a patient-centered metrics? What is the type of toxicity that you would like or you would experience if I give you an improvement of progression-free survival? More than 70% were not able to quantify, understand what is progression-free survival, and they didn't feel it was something relevant for them, regardless the toxicity administered. But the same type of interview and questionnaire really revealed that patients want to live longer, and of course they don't want to experience issues of quality of life. They don't want to have experience pain and sorrow because of the cancer, and this is one of the most important achievements that they really want to experience when administered with a new treatment that commonly can increase or bring some kind of toxicity. However, when we evaluate the landscape of the new drugs approved in the last 20 years, and this is an FDA and EMA landscape analysis appeared on JCO at the beginning of 2023, so it's a very updated analysis, you see that the median improvement of progression-free survival is 3 months. And the median improvement of all the new drugs approved of overall survival is really less than 3 months overall. And this is an analysis made of all cancer medicines, including hematological malignancies, of 124 with nearly 400 indications in the last years. And as you see, this kind of improvement that's very small, it's common. Like the drugs that have been approved in the last 20 years, 30–50% of these, they don't improve progression-free survival more than 3 months. They don't improve overall survival more than 3 months. And so I'm wondering if this is really clinically meaningful for patients, or it's not really, because this is the landscape. This is what we observe in the regulatory practice. And as you see, all these clinical trials bringing to drug approval, all of them provided statistically significant improvement of progression-free survival and or statistically significant benefit of overall survival. And if I couple this landscape analysis, PFS, OS, very small improvement in 30–50% of all the drugs, and what the patients reports, they don't really value PFS improvement for such a small magnitude. Probably statistically significant benefit does not equipoise the clinically meaningful. It's not the same. It's not, of course, what the patients expect and what they really intend as progress in the cancer treatment. And at this point, I really want to present you like a very easy, like a very common cure, very presentation of the data from the medical oncology. That's, what we work every day. This is just a clinical trial, any clinical trial. We see everyday clinical trials like this, in which 2 curves, Kaplan-Meier, are presented with progression-free survival and overall survival. And the addition of a new drug to a backbone that is the previous regimen does increase the progression-free survival of only 2 months and the overall survival of only 2 months. But when we see these curves presented, commonly there is a lot of spin and hype. And so this small and very teeny improvement that is statistically significant, and I think we all do believe this is not clinically meaningful, it will not translate in a real-world evidence in a real-world practice improvement for patient care. And of course, it will increase cost for the healthcare. These kind of results are commonly presented with hype. And I just presented some common sentences for which these kind of results are presented, including that this is a revolution. This is like a major achievement in a setting of high unmet need, hard to treat cancer, with safety that is manageable, or side effects that are acceptable according to the treating physicians or the trialist. But the reality more often is that patients may experience this very small improvement in progression-free survival and overall survival, but quality of life may be unchanged or may be reduced. And this is the case of this example that I reported. That is many examples in the clinical practice. So you see that we increased progression-free survival, that it's not patient-centric. We increased a little bit over survival, perhaps in a magnitude that does not translate in a real life improvement of patients' expectancy, life expectancy. And also we decrease the quality of life. That is exactly the opposite of patients' requests. And so at this point, I really want to discuss with you and think about what is value for patients, how we bring value to the patients' populations with the new drugs, and how we should measure this. And just to understand this, I want to present you one of the value frameworks, so like a scale that really helps us to understand the intrinsic value of medicines, that has been developed by the European Society for Medical Oncology, that is, of course, the European Society for all the cancer community, that is called the Magnitude of Clinical Benefit Scale, or MCBS. And as you see in the MCBS exercise, the value is not anymore efficacy alone, is not anymore something that is cancer-related, but it's really multidimensional, because value cannot stick to a single measurement, but is composite by definition. And being composite, it's made up of efficacy, that is, treatment-related outcomes, but also how this impacts quality of life, and if this is acceptably safe or it worsens the safety profile as compared with the standard of care treatments. And as you see here in this value framework, ESMO really separated, conceptually, this is also something we do clinically, what is a treatment used in the curative setting, in which we expose patients to short duration of very toxic treatment to make sure they are free from cancer for as long as possible to be cured, or in the non-curative setting, in which the focus is, of course, improve the outcome, but also preserve the function and quality of life. And so conceptually, we have high value in the curative and non-curative scales in the settings that are separated because the needs of patients with curative and non-curative cancers commonly are pretty different. And here I just want to display how it is displayed at value framework, how commonly, these results are displayed. It's a score, it's objective, it's evidence-based, it's reproducible, and it's based on the overall survival, quality of life, and safety endpoints, because these are patient-centric and important to capture the overall value of new medicines. And this is just, again, a way in which this kind of the intrinsic value is presented. These are scorecards visualized, with pretty straightforward and direct way, in which, again, quality of life and overall survival are the center and the focus, the heart of patient-centric outcomes and display of patient-centric values. And as you can understand, because clinical endpoints have, and new drugs have really impact on the broader oncology landscape, you can understand that the value framework should really inform value-based healthcare at all the levels. It's not really only the clinical practice, although it's very based on the clinical practice, but it's also public health, it's investment, it's decision makers, it's clinical guidelines, it's our everyday practice, and it's education. Is the way we present the data that should be value-driven and not anymore hype and spins according to very thin improvement of outcomes that are not even patient relevant. We should make sure that in our practice at every level of the cancer community, and everything is about and relevant for the cancer care delivery, investments, clinical guidelines, and so on, should be really driven by an information that is value-driven and not anymore hyped or in some way conflicted. And just to, end this initial part of the seminar, of the webinar, I really end to say, saying that clinical benefit is composite and multidimensional. It's not one metric, it's multiple metrics, patient-centric. Overall survival and quality of life and safety are the most important because they're patient-centric. It's really what patients are asking us to improve. The surrogate or secondary indirect endpoint, maybe sometimes, but not really commonly, I should say rarely correlated, with direct endpoint, but commonly alone, they don't give us a comprehensive portrait of what is the value of a drug. And that's what is clinically meaningful. It's not commonly just statistically significant improvement of the outcome. If we want to capture all the patient-centric dimensions, we need value frameworks. And ESMO has developed one of these value frameworks. Then now it's broadly utilized and now under implementation across diverse income settings. And understanding the value is important at this point, and not really only, effect size alone and non-patient-centric metrics. And just after, this very initial presentation from mine, I really want to give again the virtual floor to Dr. Khalid El-Bahiri, that was honored to meet last time in Paris. This is like some of the oncology network. We have Dr. Andreas, Khalid, and me in Paris, who will talk to you about how to enhance critical appraisal through meta-analysis of randomized and controlled trials in oncology. Thanks, Khalid, again for the invitation. And please just make your question. I'm really happy to interact with all of you.
That was a great presentation. Thank you so much, Dario, for introducing the ESMO MCBS, which is a great tool for oncologists around the world to objectively assess the impact of newly approved drugs in our daily practice. So I see that Miriam is here. Miriam, do you hear me? Miriam, are you here? I think she is coming. So, yeah, is Miriam here?
Yes. Yes,
okay.
I am.
Hello.
Hi. Sorry, I'm in transit, unfortunately, but I've been listening in. Great talk so far. Yeah.
Thanks, Miriam. Have a safe travel. So now, if you have any questions, please do not hesitate. If not, we can present the second part of the webinar and then have all the questions at the end of the presentations. What do you think? Are there any questions from our audience? Please feel free to ask, comment. So,
hello.
Yes, please, Dr. Hauro, go ahead.
Hello. How are you? Thank you for the presentation. Thank you, Dario. Thank you, Khalid. Great job. May I have a question regarding the MBBS to Dario? Is it if we measure the MBBS, we measure it on the original study that is done on the drug, or how to measure these parameters?
Yeah, thanks, Dr. Howard. This is a very important question because for now, like all the MCBS is based on the regulatory decisions. And commonly these regulatory decisions are made on pivotal clinical trials. So there is one trial, one drug and the score. But now, like since the very last update, we added something new. That is, if you have a meta-analysis of clinical trials, like Khalid is presenting soon, this can update the score and change. Because of course, it's now the pool of evidence and not anymore the single trial.
Yeah, pool of many trials, not just as the original trial of the study that's
when you have like multiple evidence and the meta-analysis is like available, this is used. And now the next step, but this is really work ongoing, it will be how to incorporate real world evidence. Because at this point, we don't really know how to use this because they are, of different quality. They are not definitely necessarily the best evidence.
It's clear now. Thank you,
Thanks.
Dr. Dario. Thank you, Dr.
Thanks,
Khalid. Thank you very much.
Any other questions from our audience? If not, then I will be very happy to share my slides. 1 second. Belmira, could you please allow me to share my screen?
Certainly.
I am trying to share my screen, but Zoom mentioned that you have disabled participant screen sharing.
Okay. There you go.
Okay, good. So I believe you are seeing my slides right now.
Yes, we can.
Okay, great. So thanks, Dario, for introducing this very important point about how to read a clinical trial toward more clinical relevance beyond statistical significance. And on my side, I am going to give you some tips and also describe some steps on how to apprise the content of a systematic review of meta-analysis and meta-analysis. This is, a very important topic for young oncologists, so they can objectively read the papers they are using for daily practice. These are my conflict of interest. I have previously reported them in the other webinars, so there is no need to talk about them again. This is the summary of my talk today. Sorry. Yeah. I will give you an overview about systematic reviews and meta-analysis, their content, the heterogeneity, publication bias, and other important parts of this very important article types. Also, I am giving you today an example of a daily practice clinical case that are going to resolve using a systematic review and meta-analysis. And also, in the end, I will talk about some concerns in the current meta-analytic approaches and also publications related to this kind of research. And of course, at the end, I have some take-home messages for our young oncologists to use accurately this type of articles. So you know that the process of drug development is a long way before approval and before having outcomes improved. This starts from basic science to phase 1 trials, to phase 2 trials, and lastly to confirmatory phase 3 trials before drug registrations and approvals. So this is a very long process before introducing new drugs. And of course, it costs a huge amount of time, research, money from industry, from academia, and this process should respect the rules of conducting human research on humans. And of course, this research can be categorized, as you know, based on the quality of the evidence. And as you can see here, systematic reviews and high quality randomized controlled trials are considered high level of evidence, despite that currently we are seeing, unfortunately, some issues in the design of these studies, despite that are considered high quality studies for our daily practice. So this attracts us to talk about the clinical relevance instead of statistical significance that is shown in this kind of article types used in preparing guidelines for daily practice. And of course, the evidence-based medicine is not only the appraisal of literature, but also should include the patient the choice and also the expertise of the clinicians. So if you have a good critical appraisal of literature, you have a patient that has choices and has also some desires to for some treatments or some other approaches, and also the clinical expertise of the clinicians, then you have the most important parts of practicing evidence-based medicine. As you know, the evidence-based medicine is categorized into 3 levels. You have already some knowledge about that. You know that meta-analysis of randomized controlled trials are considered as a high level of evidence, but unfortunately, currently we are seeing a lot of meta-analysis with bad design, with issues in the data, in the methods used to combine statistical results of other trials. So be careful when reading a meta-analysis. So today, my objective is to introduce you this type of research and also give you some steps on how to apprise that for your daily practice. The meta-analysis of clinical trials can be categorized into 2 types. We have meta-analysis of individual data, and we have also the meta-analysis of published data. So the first type is basically based on the data collected from clinical trials, but the second type uses the data collected from already published articles indexed in international bibliographic database. And also we can categorize meta-analysis according to the aim of the meta-analysis. We have diagnostic meta-analysis, prognostic meta-analysis, and also therapeutic meta-analysis. So today I'm going to focus on therapeutic meta-analysis and of published data, of course. We have also another type of meta-analysis based on the number of comparisons we do. We have the pairwise meta-analysis that compares two types of treatments, for example, and we have also the network meta-analysis that compares more than two treatments or more than two diagnostic procedures or two biomarkers, for example. So this is another type. It's difficult to be criticized in only some minutes, so we need a lot of time to discuss about that. But today I am going to discuss the pairwise meta-analysis as an example. Today I am going to discuss a pairwise therapeutic meta-analysis of published data, which means that we are going to see a lot of forest plots, as you can see here in this slide. And this is not important, I guess. The first step of appraising a meta-analysis is to check the flowchart of selecting the articles to be included in your meta-analysis. This basically should follow the PICO criteria to respond to a very focused questions, because this is different as compared to critical or narrative reviews. The systematic review, which is the first part of a meta-analysis, should focus only on one question. For example, if this treatment is better than this one, or this biomarker is more specific or sensitive than this one. So it's a very specific question that you need to answer based on a systematic review, and basically it should follow the PICO criteria. One very important take-home message from this slide, which is just describing how to find articles, how to select them, how to include them in your systematic reviews based on your eligibility criteria before inclusion at the end, because the inclusion is the second part, which is going to combine the data from a lot of clinical trials as a meta-analysis. As I said, the take-home message here, please be careful when you see references excluded. References excluded should not be negative trials, because unfortunately in the current systematic reviews, we are seeing a lot of systematic reviews and meta-analysis with negative trials being excluded. This is bad, because when you combine positive data from a lot of trials, you will have a positive meta-analysis at the end. Because unfortunately, trialists and investigators sometimes they don't want to include these negative trials because they will affect the final overall effect of the meta-analysis. So a good meta-analysis should always include negative trials and not exclude them. Also, one very important part of a meta-analysis to be read and discussed in details is the risk of bias. In a systematic review, which is the first part of meta-analysis, you will have this picture, which is just a summary of the risk of bias, which is also called the ROB tool. So in this risk of bias tool, you will have the articles that you are including in your systematic reviews, basically the clinical trials, and you have the criteria of quality to be assessed for. For example, the random sequence generation. If it was described in details in the trials, you will find this symbol plus. If it was not clear, you will find this. And if it was not really described in details, you will find the points here. And also, there are other very important criteria to be checked, like blinding of participant and personnel, blinding of outcome assessment, incomplete outcome data related to endpoint, for example, if the reporting guidelines were used or not, and other bias, if they were checked for or not. So this is just an overview of the quality of the trials that you are including in your meta-analysis. So one very important step when reading a meta-analysis that you need to have this general summary of the quality of case studies included in your final paper or for your final conclusion, of course, and this can be categorized into low risk of bias, high risk of bias, or it's unclear. So I strongly recommend that you check this diagram when you read your meta-analysis for your daily practice. This is something very famous in a meta-analysis, which is called a forest plot. The forest plot basically contains studies included here, the number of participants in each group, you are comparing an intervention versus a control. So you have a sample size of each group here mentioned, and you have also this line, which is called the line of now effect. The line of now effect is just the hazard ratio equal to 1. So you have also the hazard ratios from included clinical trials and their confidence intervals, and you have the final overall effect. So the final overall effect is just the combination statistics of the all hazard ratios based on some statistical analysis by the software used. So there are a lot of kind of statistical approaches to combine results from these trials, like random effect, and also there is the fixed effect. And as you can see here in the line here, you have, for example, this study, it has a hazard ratio superior to 1 and a small study sample. So we will have this small point here. So it is correlated with the sample size of the study. For example, here in the second point, it's bigger. It has a small confidence interval because the sample size is high. So at the end, you will have the overall effect here. When it touches the line of no effect, it means that there is no difference between the two comparison. When it is on this side, it favors the intervention, and when it is more than 1, it favors the control. So this was just a summary of a forest plot, and there are a lot of very interesting results that you need also to apprise in a forest plot, including the test of overall effect, if it was significant or not, and also the test for heterogeneity. So in a lot of cases, you can have the overall effect more favoring, for example, the intervention, but you have a lot of heterogeneity. So here, the E-square is a heterogeneity test that gives you an overview of the heterogeneity among studies included. When it equals 0, it means that there is no heterogeneity, and the overall effect can be taken as a conclusion to be further analyzed. But when there is a lot of heterogeneity, more than 50%, for example, then be careful. You need to check for single group analysis and for other approaches like sensitivity analysis. So the first, as I said, the first step to interpret a forest plot is to check for the overall effect and the confidence interval, and also to check for the heterogeneity. This is a very important step before going to the next step to apprise a meta-analysis. So dealing with statistical heterogeneity is important because sometimes even if the study was randomized, you can find some heterogeneity related to ethnicities, to age, to comorbidities, to covariates in general. So you need to check the details to see if this heterogeneity can be fixed for using a random effect model, or there is no heterogeneity, and then you can use the fixed effect model, which is widely used with there is no heterogeneity or low heterogeneity. So basically, the E-square statistic can give you this information. When it gives you a number like between 0 and 25%, there is low heterogeneity, then you can take the final overall effect as a conclusion. But when it's moderate or high, then be careful. You need to check for to overcome heterogeneity, and basically meta-analysts use subgroup analysis, sensitivity analysis, and meta-regression to limit the issue of heterogeneity among studies in this meta-analysis. As I said, heterogeneity unfortunately can be seen in meta-analysis of clinical trials, and this can be unfortunately associated with covariates, even if the study was randomized. So adjustment for covariates in clinical trials is very important, as you know. One another step is to check for publication bias. Publication bias can subjectively check it for using the funnel plot. The funnel plot is just a summary of the effect size of each study. When there is a summary, when there is a symmetry, excuse me, when there is a symmetry among studies, this means that there is no study that we left behind. Because basically in a funnel plot, you will describe the study effect size of each study. And if there is a study that was published but not included, you will not find the circle, the point related to this study. So basically an asymmetric funnel plot means that there is a study that was excluded or not found or not included in the final review of studies to be included in meta-analysis. And of course, this is subjective, so we need something more objective. We have the degradation Gertz test. When it is significant, it means that there is publication bias among studies. But be careful, you should not use any funnel plot when the number of studies included is less than 10 studies, as per international definitions of publication bias by the Cochrane initiatives. Let's go ahead with an example with a clinical case from our daily practice. We have a 44-year-old woman with a history of breast cancer in the family. She presented with abdominal and pelvic pain. When you did imaging, you found 2 hyperechoic bilateral ovarian masses with increased vascularity, with peritoneal deposits and acids, and also with involvement of bowel and spleen. The cancer antigen biomarker was high, and when you did the laparoscopic biopsy, it was a diagnosis of high-grade serous ovarian carcinoma, staged as FIGO 3C. So you are in a multidisciplinary team, you are a resident in oncology, for example, you want to propose new adjuvant chemotherapy, or you want to defend debulking instead. So we want to know, if we do a new adjuvant chemotherapy, are we going to gain something related to quality of life, to overall survival, progression-free survival? So we need to defend the new adjuvant chemotherapy as compared to debulking for this patient, for example. So let's suppose you are just a resident in medical oncology. You will go to PubMed, of course, go to the MeSH database. Then you can check for ovarian cancer using ovarian neoplasm MeSH term, because it will give you a lot of papers related to the topic. Then here is, for example, you found, you select the second keyword, which is adjuvant therapy. Then you will find, let's see here, more than 600 papers. This is a lot to respond to the questions. You need to narrow your search. And of course, we find during the last 5 years, the newly published papers are more than 300. This is also a lot. You need to narrow more. And we check here this criteria to only select meta-analysis. And we found like 6 or 5 meta-analysis trying to respond to this question: if new adjuvant chemotherapy is superior as compared to debulking in terms of overall survival, progression-free survival, and quality of life. So I will just randomly select this one because I'm a beginner. As a resident, I don't have enough skills to check which is the best to date. So I checked, for example, this meta-analysis, which I made to systematically evaluate the influence of new adjuvant chemotherapy on survival and complete hysterectomy after debulking surgery in advanced epithelial ovarian cancer patients. So I will use this example to further explain to you how to appraise a meta-analysis. So this is an overview of studies included in the final meta-analysis. You have here, unfortunately, conference abstracts being excluded, which means that maybe there are some trials that compared these 2 interventions, but they were not included in the study, in the meta-analysis. So this is one bad thing to see in meta-analysis, but let's just check the first studies included in meta-analysis to respond to our questions. When checking the risk of bias tool, basically all of studies were great, except for the ROSE study published in 2004, where the authors did not really talk about random sequence generation, allocation, concealment in the design of these trials. And of course, when you see these points for all the trials, blinding of participants and personnel is something that you can accept because it's a surgery trials, and then you cannot really blind the surgeons to operate their patients. So this is something acceptable for now. And basically, the studies included are of good quality based on the risk of bias tool. We check in the forest plot very rapidly. The forest plot for overall survival touches the line, which means that there is no effect related to the overall survival. This means that when you start NACT or you do debulking, there is no gain in terms of overall survival. Also, when you check for progression-free survival, there is also here the overall effect touching the line, which means that we don't really gain anything in terms of progression-free survival. And unfortunately, even if it was interesting when the overall effect was on favoring NACT, but here you have heterogeneity, which is moderate, and it limits the conclusion of the results related to progression-free survival. Going more into the details, when you check for the debulking rates, this is interesting. In fact, for surgeons, we found that NACT favors now residual disease, favors residual disease less than 1 centimeter, and also optimal CT reduction rates. So this means that when you do neoadjuvant chemotherapy before doing surgery, then you can provide something very interesting to the surgeon, because he can now operate effectively and without really just closing the abdomen and sending it to you for chemotherapy. This means that they can increase the debulking rate, and this is very interesting. And when you check the heterogeneity here, it's 0%. So these results are interesting for the surgeon, and let's say they are of good quality. So we have less than studies in study, so we cannot evaluate the publication bias in our study. This is a very important criterion. When we check for the source of heterogeneity using the I-square from sensitivity analysis, for example, in addition, you can do subgroup analysis, you can do meta-regression, but here the authors did sensitivity analysis. They found that the Vanderburg all probably contributed to heterogeneity, and after excluding the study, the results suggested that overall survival of patients was still similar between NACT and primary debulking surgery. So this means that the meta-analysis finding was not affected by the heterogeneity of this study. When you look more into the details, the Vanderburg study unfortunately had some large residual tumors. So for this reason, we found this heterogeneity among studies. When you check the NCCN guidelines, you can see that based on this appraisal and the references of NCCN, we currently recommend the neoadjuvant chemotherapy for FIGO stage 3 for patients who have bulky tumors that cannot be removed during debulking by surgeons, because it increases the debulking rates and it optimizes the surgery for this patient, but there is no gain in terms of overall survival and progression-free survival. So this is something that every resident in medical oncology can do to justify his management. Now we are going to see something advanced based on the Cochrane library. The Cochrane library is very interesting because the meta-analysis and systematic reviews published here are being conducted by experts in the field. So it's trustworthy to use it for your daily practice. We did the same bibliographic research. I found this very interesting meta-analysis about the same topic. I am going to discuss it with you right now. So this meta-analysis tried to answer the same question about the neoadjuvant chemotherapy impact for FIGO stage 3 or 4 or more as compared to cytoreductive surgery for this setting. So when you check the details, you will find a lot of very interesting results that are more relevant to experts in the field, for surgeons, for advanced practitioners, like the bowel resection effect, stoma formation, the post-operative mortality within 30 days, quality of life, and other outcomes that were not assessed, not studied with that, let's say, standard meta-analysis. And also it uses the GRAD approach to appraise the quality of the evidence. And when taking the conclusions of the study, it's the same conclusion: doing NACT or surgery first for advanced ovarian cancer, now gaining overall survival, now gaining progression-free survival. But it's very important to help and optimize surgery for patients and quality of life also. So this was just a summary of meta-analysis. There are a lot of details. I don't have time to discuss them. So now the question, what if there are a lot of meta-analysis on the same topic? You are conducting a bibliographic search on PubMed. You found a lot of meta-analysis being published recently, but what is the best one for your appraisal? You want to defend your treatment approach, but you need the best paper to be used as a reference. So this is not important. This is just the latest trial from Italian colleagues from Anna Fagotti team. This is the latest clinical trial that tried to answer the previous question with more adjustment for the issues of the previous trial. This is Scorpion trial, in fact, and it has the same conclusion as the previous meta-analysis. So now, as I said, when you have a lot of meta-analysis, what to do to select the best one? So I am going to introduce something called the umbrella systematic review of meta-analysis. This is a type of article that is newly introduced into the literature, and it tries to apprise the content of meta-analysis in terms of quality. So I was happy when publishing this first umbrella systematic review from our team. It is not about NACT and surgery for ovarian cancer. It's about biomarkers, but I'm just trying to introduce it to you because it's important. It will help you to select the best meta-analysis for your daily practice. So it's the same thing as a systematic review. You will select meta-analysis, screen them for eligibility criteria, and include them. In this case, we included more than 70. It was 70 papers as meta-analysis, including qualitative synthesis. We use the AMSTAR2. The AMSTAR2 tool is a score that you are going to use to check for the quality of the meta-analysis being published or already available for citation. So it's more than 10 questions that you need to answer, and at the end you can apprise the quality of the evidence of the meta-analysis that are available for use. And of course, doing a grad approach is important in umbrella systematic reviews because it can give you the certainty of evidence. And unfortunately, this umbrella systematic review provided me with some concerns in the present meta-analysis, because the umbrella systematic review is a type of article that is published to apprise the quality of meta-analysis. So when you have a lot of meta-analysis, you can search for an umbrella if it exists, and then check for the best one that was apprised as high or moderate quality, and then you can select it for use as a reference. So now in this umbrella systematic review we published, we found, unfortunately, that there are a lot of redundant meta-analysis. People are publishing meta-analysis without newly published original studies. It seems that people are publishing just for publishing, because when you want to make a new meta-analysis to be introduced into the literature, you need a new evidence. You need a new trial that is negative or positive, so you can add it to the previous evidence. But unfortunately, a lot of redundant meta-analysis. So when I looked more into the details, I checked the systematic review to see why non-concurrent systematic reviews are being published and have flawed concerns. I found that a lot of them are being retracted, and there is an increasing number of non-concurrent systematic reviews in medicine are being retracted because of fraudulent peer review and unreliable data. This introduced us to something that we have previously discussed in the webinars about the paper mills. People are just buying meta-analysis and adding their names, and they are publishing them without really checking for quality, for heterogeneity, for publication bias, and answering the right question in the meta-analysis. So people are just publishing to publish, unfortunately. And when we check the details of the systematic review, and it's really interesting, you need to read it, there are a lot of issues related to fraudulent peer review, authorship issues, because basically this meta-analysis of low quality are being published by authors who did not really make the systematic review. They are just buying them and add their names, and this is something frequent that we are seeing in the meta research system, where there is something we discussed previously called the paper mills. Paper mills is a phenomenon of papers that are being published without involvement of the authors listed in that paper. So it's a money-making machine, unfortunately, and they are fortunately retracted because of plagiarism in reliable data, duplicate publications, data fabrication, other related factors that were discussed in the systematic reviews. One example here is this meta-analysis of the association between TNF and interleukin-6 gene polymorphism in susceptibility to lung cancer. Later, when this article was published, we discovered that the meta-analysis was not published by was not conducted and published by the authors. They used a third-party service that made meta-analysis and also published it instead of the authors. So it was very, very low quality, unfortunately. And this might hurt our patients because, as I said, meta-analysis are high quality evidence sometimes. So when you use very, very bad evidence from this kind of research, you can hurt your patients because we use them to update guidelines, to provide therapeutic strategies for our daily practice. So please be careful about the meta-analysis you are reading because sometimes they are flawed and they are not really answering the question that we need to look for. This is another example of an article, a meta-analysis that was retracted. It studied the efficacy of pancreatoduodenectomy with extended lymphadenectomy in treatment of pancreatic cancer. So if you are a surgeon and you are reading this meta-analysis, you might hurt your patient by selecting the wrong procedure for your patient because the meta-analysis was flawed and it was not real. It was falsified. It was the authors bypassed the peer review process, and of course the integrity of the article was compromised, and the details of meta-analysis was just fabricated by the authors. Fortunately, in fact, the journal has retracted this meta-analysis, but believe me, there are a lot of other meta-analyses that have these flaws and are still being cited in our daily research. The take-home message before concluding for our young oncologists: before reading a meta-analysis, you should always check if the question is being correctly and adequately answered by the authors. They should always adhere to the PRISMA guidelines, register the protocol on Prospero or other database, do a systematic research for articles without excluding negative trials, have always a clear definition of inclusion exclusion criteria, check for heterogeneity, check for risk of bias, the risk of random errors, the statistics being used, the effect or the random effect, the quality of the evidence using the grad approach, and also if the conclusion is really supported by the evidence being studied in the meta-analysis. And of course, in some cases, the competing interest might interfere with the conclusion of the authors. So be careful when reading this kind of research because it might hurt you and also hurt your patients. There is currently a great course from the Cochrane Initiative. Just go there and you can get a lot of knowledge, free knowledge, of course, open source for all young oncologists and senior scientists to update their knowledge and check for the quality evidence available for use. And there is also something, if you want to conduct a systematic review and meta-analysis, there is a great Coursera-based course from Johns Hopkins University where you can get some knowledge on how to conduct a meta-analysis and respond to your daily questions related to your setting. Thank you so much for the AWARTIC. I need to thank Professor Miriam Motibi, the AWARTIC advisory board for accepting to make this research integrity seminars a success. This is the last event we prepared together, and hopefully we can do more in the near future. So please follow the emails from the AWARTIC. They will send you a survey, so please try to fill in it. I would like to acknowledge the participation of a lot of colleagues and friends to make this webinar successful. Professor Miriam Motibi, the AWARTIC advisory board, people who are behind the screens, Sky, Bill Mira, Khatija, all of them did great. We could not really make this success without of them. My supervisors here, our colleagues from Oncology group, Dr. Dario Trapani, Mariam Fortasi, my professors, Dr. Lauren, who joined us recently, my institutions, the ASCO for giving me the column on the ASCO connection to share some of my insights, And that's it. Thank you so much for this, and I will be very happy to take some questions.
I think, Khalid, there is a question for you in the chat. I will read this for you. First,
by the way, I don't know if did you hear me well during the presentation, because I had a stable connection?
I heard you very well. I think everybody did, but for me it was very clear, and connection was fine, really. I hope it was the same for other people. So there is one question, and it's about how you assess the risk of bias, this risk of bias assessment in meta-analysis. Someone is mentioning that he uses, Dr. Ahmed, he uses ROB2 tool. He's wondering if you do this manually, if you use a software, and what particular software.
Okay, yeah, that's a very interesting question, in fact, for all meta-analysts that want to conduct a systematic review and meta-analysis. Looking for publication bias in the systematic reviews and meta-analysis is based on something we call the funnel plot. So the funnel plot is subjective. It is it can be conducted using all softwares available for conducting systematic reviews and meta-analysis. There is that one from the Cochrane. I still don't remember its name, but it's open source and freely available for everyone. There are statistical analysis associated with this funnel plot, the Eggers test. But before doing it, you need to check for the number of included studies. When it's around 10, you can do it. But when it's less than 10, then statistical power of the test is not interesting. So you cannot go further. Regarding the risk of bias tools in included studies, we use the ROB2 tool when the meta-analysis is of randomized and controlled trials. So the risk of bias tool is from Cochrane library. It's freely available. You can do it manually or you can do it electronically. There is the online platform for that, and you can also download the tool and doing it manually. But you cannot do it alone. You need another investigator and a third one to check when there is discrepancy between the opinions. It is used freely, as I said, by the Cochrane software and also by other softwares available packages. This is when you are conducting a meta-analysis of randomized and controlled trials. But when the meta-analysis is of observational studies, then this tool is not adapted. You need to use the Newcastle-Ottawa scale, and it's something similar, but it is more adapted for observational studies. I don't know if I have answered your question.
Thanks, Khalid. Dr. Ahmed, if you have any other comments, just type in the chat. I see Professor Mutebi has also 2 more questions. One is for me, and it's how we adapt some of the ESMO tools like the MCBS to the African context. I think this is a great question and point, because these tools were really originally shaped around, I think, the European environment, like EMA, like this kind of regulatory environment. But there are now efforts ongoing to understand how we can improve to operationalize these tools, how we can adapt the interpretation at the local level in a more relevant tool at the ground level, in particular for the African level. So it's really going in progress, it's ongoing, but it's definitely some of the questions that also at ESMO, we have done to ourselves to understand how this can become a global tool and not only, of course, something that can be used in selected countries. And I agree with Miriam that at this point, it's something that we have to think about for sure. And then we have also a question from Dr. Mutebi for Khalid, and is what kind of advice we can give to young oncologists when they encounter scoping review versus systematic review, how to interpret and how to get the information in that. So please go ahead.
Yeah, this is also a very important question, because we have a lot of types of reviews, including systematic reviews. So sometimes it's difficult to select the best one to answer your questions. So basically, narrative, critical, and scoping reviews are very general. They don't answer only one question. So a systematic review, as you know, uses a PICO criteria. So it should respond to only one question. So one very important take-home message here is that when you are conducting a systematic review and you find that there are a lot of heterogeneity among studies, this means that studies are not really similar in their design, in their inclusion criteria, in statistical approaches used, etc. You can switch to a scoping review and make it like a critical review of the literature, because a systematic review should be very narrowed in terms of inclusion criteria and other criteria. So you need really to answer only one question. But when, unfortunately, in some cases, when you are including studies trying to answer the same question, but you found at the end that there is a lot of heterogeneity, for example, that please switch to an overview of the studies, a scoping review, and it is also something that we can publish, because publishing a systematic review with high heterogeneity will not really bring something interesting for our daily practice. And it can, I don't know how to say that, but it can provide something that we consider a high level of evidence, but in reality, it's not high level of evidence because of high heterogeneity. So scoping reviews are always great when there is a lot of heterogeneity, and systematic reviews and meta-analysis are greater when you have less heterogeneity and the studies are of great quality. And maybe I think Dario may add something related to that. I don't know. This is just my humble experience.
I agree with you. Like, of course, I really feel this redundancy of meta-analysis because, they really score your curriculum with like an effort, but sometimes we just don't need some of them. Really, when all the clinical results are very clear, you don't need to make a meta-analysis. And this is like a common mistake I see, when all the trials are the same, you just reconfirm, like the results that you already know. It's just adding anything more. And you don't really explore any subgroup because, of course, there are limitations in that. For the scoping review, I think they're important when you want to shape, like you want to understand the landscape, you want to get the unmet need and opportunities, like SWOT analysis, things like that. It's important to have, but from scoping review, you don't get really like any answer. You really get just a path, like a way, a landscape, and then you understand what's missed and how you can produce your own research in that like unmet need space. So yeah, I totally agree with you. I really also enforce your messages about that. In particular, thanks for sharing all the tools. I think they're so precious, and all the resources in your presentation. I took note, of course, for myself as well. And I will share, with my peers, my colleagues and fellows as well. Do you want to add anything more? Even Miriam, I know you're connected. Perhaps if you want to type, just feel free, because you may have issues in taking the audio. And please, everybody, if you have questions, type in the chat or just take the floor.
Yeah, until we receive more questions, one important thing related to critical and scoping reviews, in fact, is that it can give you overview of what exists in the literature, so you can find the best resource topic for your setting. For example, when I started looking for research topics related to my field, ovarian cancer, particularly biomarkers, I conducted a literature review, a critical review of literature, and then selected what are those biomarkers that are affordable in my setting, and then conducted a systematic review on those particular biomarkers. So a critical review or a scoping review are always something interesting for young oncologists to start with, because first it can give you some expertise in searching the literature. It can give you also some expertise in discussing the results of other studies. It may allow you to have more confidence in writing articles. It can also give you a general overview of what exists, so you can focus on that and build an original research topic. So yeah, I strongly recommend to young oncologists to publish first reviews, and then they can conduct based on that some original topics relevant to their daily practice. So I am seeing here some comments. Okay. Okay. We should not forget that in the upcoming days, in early November, we have the Aortic Annual Congress in Senegal, in Dakar. it's a great event to come and interact with our African and international oncologists from all the globe. We are going to be there to discuss our daily management of cancer in Africa, to discuss research collaborations. You will have the opportunity to interact with great oncologists, Professor Mariam Motibi, Nazik Hamad, and other leading African oncologists will be there. So please try to check the screen. Here is the contact email if you need some additional information. We have also a great website built by our tech people who works behind the screens. They do great. They really did great to make this successful. So please go there and register as soon as possible, so we can meet there. I will be there. I hope I will do my best to come, and hopefully we are going to discuss this more. And I think Miriam needs to say something. Yeah, Miriam asked the question on a brief comment for review for qualitative studies. I can say that I am zero in qualitative studies. I have no great knowledge in the field, but let me say that I don't know. That's it. I think that's the best answer for this kind of question. To be honest, I cannot comment on something I don't really know, particularly the details. So if any other participants has any comments about or answers about that, then it will be great. Dario, can you comment?
Yeah, thanks. I mean, the problem with qualitative studies, we had some survey project in the past, as so they are still, qualitative, is that you have to, to transform, the qualitative data and quantitative data, to make measurements. So the only way really to make first qualitative review is probably to use structured, questionnaire or things that you can measure and it's validated. But sometimes this is not enough. When you have all, narrative medicine or really even sometimes psychology related studies, you really need to capture patients' voice and opinion. And in that case, it's really more navigating with some structured tools to understand what is like semantic areas or domain that patients want to share. But I think it's still like a challenging field in a way that, of course, interpretation reporting of these kind of results are very challenging because we don't really have very good structured way to do. And that's a common issue in the interpretation of this evidence. So at this point, I'm not really sure I have the solution, but it's definitely something we should pause and think about.
Any other comments, questions? Believe me that the presentation we did today, it was just an introduction into the field. So you need to get more knowledge, try to get more training. There are a lot of great resources available from Cochrane Initiative, from the Common Sense Initiative too. So please try to get more knowledge about evidence synthesis. It's something really very interesting for your daily practice, for research too. So you can adequately appraise the content of studies for your daily practice. Do not forget that the final destination of all of this is our cancer patients. And also, this is also great for people who want to conduct some research in their setting. And meta-research, including critical reviews, narrative reviews, systematic reviews, are something that you can do without having funding. So go and get more knowledge. And I think that's it. Professor Miriam said that the challenge is heterogeneity in these studies. Yes, that's a real challenge. There are some tips that statisticians provided to exclude heterogeneity, but it's an alternative. It's not a final solution. You can do meta-regression. You can do sensitivity analysis, subgroup analysis, etc. But when you resolve the problem, you will have more additional problems. When you do, for example, subgroup analysis, you will decrease the sample size, and the sample size is very important when you check for confidence intervals. So it's not a perfect field. So you need to know that. So Yeah, let's see. In challenges heterogeneity in this, some tools exist but not really robust. Very much. Yes, exactly, Miriam. There are a lot of tools, but they need improvements. Statistical approaches available are being every day improved, but unfortunately, they are not included in the packages, the statistical packages, very fastly. So we need years and years before, sorry, before using them in statistical packages we use for statistical analysis. So unfortunately, Miriam is not with us, but we feel she is with us today. We hope to see her and meet her at the Hour Tech. Thanks again for joining us. Thanks for Dario. Thanks for being here. Thanks for Bilmira. You are doing great. Always, you are the best for this kind of organizations. You supported us a lot. We did great webinars together. Sky, Khatisha, all our tech members and colleagues, Miriam, Nazik Hamad, Verna. By the way, Verna is a FASCO right now, so congratulations for her. Thanks, Dario, again. Thanks for everyone. This was an initiative with what we have available in our hands. We hope to do more in the future. And that's it. Thanks again, and maybe see you soon.